iGlaucoma presents a video series.
Gateway to Safe Suture GATT. Gonioscopy Assisted Transluminal Trabeculotomy, or GATT, is the brainchild of Dr. Devinder Grover and Ronald Fellman from Glaucoma Associates of Texas, Dallas. The surgery involves an ab interno canalization of Schlemm's canal and achieves 360 degrees of trabeculotomy. This procedure is conventionally done with an expensive illuminated microcatheter. Alternatively, in the developing world, one can do this procedure using a low-cost 5-0 Prolene suture. Like learning any other new procedure, learning suture GATT is also a challenge and requires practice and perseverance to master it. It is like learning martial arts in a Shaolin temple. Here are the must-have items for performing suture GATT. 5-0 Prolene suture, low-temperature cautery, direct Swan-Jacob gonio lens, high viscosity ophthalmic viscosurgical device or OVD like Helon GB, 25 gauge MVR blade, MSD forceps, McPherson's forceps. An ideal suture GATT surgery involves the blunting of the tip of a 5-0 Prolene suture using a low-temperature cautery to make a small flange. Following this, the suture is introduced into the anterior chamber under OVD. A small 1 clock hour initial goniotomy is made in the trabecular meshwork using the 25 gauge MVR blade, and then the flange suture is introduced into Schlemm's canal using MSD forceps under Swan-Jacob gonio lens visualization. With gentle strokes, the Prolene suture is advanced into the canal till it appears from the opposite side, where it is grasped at the tip, above the initial suture, and brought to the center of the anterior chamber. Finally, using McPherson's forceps, the external suture is pulled out, achieving a 360-degree ab interno trabeculotomy. In this movie, we share some beginner's complications, and we will also focus on 6 important tips and tricks to avoid them with a simple A, B, C, D, E, F. A. Angle visualization. Initial intraoperative gonioscopy can be practiced on routine cataract cases before initiating or after completing the surgery. Tilt the patient's head 30 to 35 degrees away from you and tilt the microscope 30 to 35 degrees towards you. Put a drop of OVD on top of the cornea and gently place the Swan-Jacob gonio lens over this drop. Adjust the microscope magnification, start from a lower magnification, and then slowly increase it using the microscope foot switch till you get a clear view of the angle structures. Initially, during intraoperative gonioscopy, one will have air bubbles in the anterior chamber or too much pressure over the eye while placing the gonio lens, which can result in folds over the cornea and failure to see the angle properly. It takes a few cases to master this technique to visualize the angle perfectly. It will also be good to routinely practice the foot switch of the operating microscope, as both hands get engaged while doing MIGS, so finer adjustments need to be done using the microscope foot switch. B. Blunting of the suture tip to get an ideal flange. The tip of the 5-0 Prolene is blunted to form a small flange using low-temperature cautery. This is to make it atraumatic and facilitate its smooth passage into Schlemm's canal. An important tip: keep the low-temperature cautery a little ways away from the tip to get a just needed flange. If the cautery comes in direct contact with the suture tip, the flange gets too big for the size of the canal. This may result in difficult entry into the canal, excessive bleeding, or may even create a false passage. C. Check for correct passage. In addition to a perfect flanged tip, there is another way to ensure that the suture is in the canal and has not taken any other path. This is to perform an indirect gonioscopy, on the table using a sterile single mirror gonioprism. The blue color of the Proline suture helps in identifying its presence behind the trabecular meshwork, i.e. in Schlemm's canal. This will also give us an idea as to how many clock hours have been traversed and how many clock hours are still remaining. An important tip: the direction of the strokes should be circumferential rather than perpendicular to the goniotomy. What happens if a false passage is created inadvertently? The suture can go into the suprachoroidal space and cause a choroidal detachment, which can be managed conservatively with oral and topical steroids, and in most cases resolves within 15 days. D. Descemet's membrane detachment. A DM detachment can happen in the process of threading the suture into the canal using MSD forceps while regrasping the suture each time for advancement. The upper blade of the MSD forceps can touch the Descemet membrane, causing a localized detachment nasally. Tips to avoid this complication. 1. Keep the anterior chamber deep by filling it with OVD. 2. Work away from the cornea while opening the MSD forceps to grasp the suture. And 3. Avoid opening the MSD forceps fully. Open it just enough to grasp the suture. E. Experiencing resistance in the canal. As the Proline suture passes through Schlemm's canal, resistance is experienced when it reaches 180 degrees, as it has to turn to the other side. It is an indirect sign that the suture has reached 180 degrees, but sometimes it doesn't proceed beyond this point. Tips in this situation. 1. Try twin site GATT, which means threading the suture in a clockwise direction rather than the initial counterclockwise direction. 2. Leave the suture at the site of resistance, then try to localize the suture using indirect gonioscopy on the table. If the suture has reached 270 degrees, then try to make a small goniotomy at that site and retrieve the suture by making a new paracentesis located 180 degrees opposite to the site last reached by the suture. F. For better canalization, avoid bleeding. Make all incisions on the clear cornea to avoid any bleed from the limbal vessels, as this can result in poor visualization. Tips to avoid reflex bleeding from Schlemm's canal while making the initial goniotomy. Keep the patient's head above the heart level by lifting the head of the bed in a reverse Trendelenburg position. Also, pre-fill and pressurize the anterior chamber with high viscosity OVD. We are sure that by implementing these tips during the learning stages of suture GATT, one can achieve desirable results and also ensure a safe gateway to successful suture GATT.
I never would have suspected that the boy would develop so quickly.
Thank you.
Want to help with improving your glaucoma patient's adherence? Want to know the best kept secret behind better doctor-patient relationships and more patient trust? The answer lies in improving glaucoma patient education, an unmet need. I'd like to introduce you to the Glaucoma Guidebook, Expert Advice on Maintaining Healthy Vision, vetted and published by Johns Hopkins University Press. This book is a pathway to empowerment for the glaucoma patient through enlightenment, understanding, encouragement, and direct advice to become a self-advocate for blindness prevention. This, for the provider, decreases chair time and explanations and enhances the doctor-patient relationship through care, increased trust, and ultimately, the patient getting on board with treatment plans for better outcomes. The Glaucoma Guidebook. Get your copy today, then share.